Hello everybody, this is Suphi Taneri speaking from Münster, Germany, and I would like to talk about how to fit phakic IOLs in a refractive practice today. Patients are often surprised to hear that the first phakic IOL implanted in the posterior chamber was presented by Fyodorov in the year 1986, and phakic IOLs in the anterior chamber were implanted even before that, so way before laser vision correction came about. Today we want to talk about when to implant phakic IOLs, which type, and the benefits and pitfalls. When evaluating patients for refractive surgery, I always have this stepwise procedure selection in my mind. I always choose the procedure that does the job with the least amount of invasiveness. So for most of my patients, this is some kind of laser vision correction. If this doesn't work, then I think about phakic IOLs. And if they don't work either, then I do refractive lens exchange. So the typical indication for phakic IOLs are an irregular cornea that you don't want to do laser correction on, or some high myopia in the presence of a clear crystalline lens. Also, a status post-cataract surgery in the partner eye in a pre-presbyopic patient, and status post-retinal detachment can also be a special indication. So, phakic IOLs require an anterior chamber depth of 2.8 mm or more. Phakic IOLs are also available for hyperopia correction. However, oftentimes the anterior chamber is too shallow for implantation in hyperopic eyes. Anterior chamber IOLs we have been using a lot in the past. However, we encountered some complication like iris atrophy, haptic entrapment, and endothelial damage with the chamber fixated IOLs, and giant cells and dislocation with the iris fixated iris claw IOLs. So I personally don't use them anymore. Posterior chamber IOLs are available in various types today. The most popular one is the ICL, and the ICL may be regarded as the gold standard for posterior chamber IOLs in phakic eyes because of its proven safety and efficacy. Oftentimes the term ICL is used synonymously with phakic IOL implantation. However, there are at least 3 other models available, one of which is the IPCL, and then we have the refractive implantable lens and the acryl phakic IOL. So the ICL has been available since 1993, and it comes with an aquaport, a hole in the center, since 2012. It has a range of +10 to -20 diopters with up to 6 diopters of toricity. Of note, the ICL is not commercially available in a presbyopic version right now, although the presbyopic version has gained a CE approval in 2020. The IPCL has been available since 2012 and has a broader range from plus 15 to minus 30 diopters with up to 12 diopters of toricity. It has a presbyopic version with multiple near adds. So this is the IPCL presbyopic. On the left hand side you can appreciate the diffractive optic, and you can see how easily it is to insert the IPCL into its cartridge, similar to a cataract IOL. So this is the ICL on the left hand side and this is the IPCL on the right hand side. We wanted to compare the latest versions of both phakic IOLs for myopic and myopic astigmatic correction. And here you see some post-op findings at the slit lamp on the left hand side, and down below on the anterior chamber OCT, where you can appreciate that we have a good vaulting without touching the crystalline lens. The IPCL, as the ICL, has a toric version also, and the IPCL, as I said, has a presbyopic correction with diffractive optics. So looking at the uncorrected visual acuity after 3 months in those eyes with plano target, we found more than 90% within 1 line of corrected visual acuity pre-op with both models. Moreover, a similar number of lines of corrected visual acuity was gained with both eyes. Regarding spherical equivalent refraction, we observed an excellent correlation with both IOLs up to approximately 20 diopters of myopia correction. Similar, the results in terms of astigmatic correction were comparable. Also, the list of adverse events in the last 10 years was similar. There was a more frequent need for secondary intervention after IPCL implantation, mostly because of a rotated toric IPCL. Cataract occurred twice after IPCL implantation and 4 times after ICL implantation, and the vaulting was perfect in all of these highly myopic eyes, and cataract formation seemed to be age and myopia related. 2 years after implantation of the IPCL and of the ICL, we observed no significant endothelial. Similarly, the intraocular pressure was comparable with both phakic IOLs. So in conclusion, phakic IOLs are indispensable for a comprehensive refractive surgeon, especially in irregular corneas where you don't want to do laser vision correction. Also in high myopia or high astigmatism outside the range of laser vision correction. The beauty is that accommodation is preserved with phakic IOLs, and the IPCL seems to be a promising alternative to the ICL, especially in presbyopes. Thank you so much for your kind attention.